Hello and welcome to this month's episode of the Atrium. I'm Dr. Alice Copperwheat and I'll be joined this month by Dr. Segmentectomy and we're going to be talking about the topic of segmentectomy. So I think this is a really important topic to get our hands in, but first I want to start by getting to know our guest. Dr. Agathe Seguin-Givelet is a thoracic surgeon working at Ambroise Paré Hartmann Hospital in France. Her initial training was a combined thoracic vascular, but then she started specialising in thoracic surgery and mainly lung tumours. She's really involved in minimally invasive surgery, including rats and VATS, and is an expert in segmentectomy, so there's no better guest that we could have on. And is really at the forefront of trying to advance the minimally invasive segmental resections. Welcome to the podcast.
Yes, thanks, Alice. I'm very glad for your invitation.
Good. And I just like to always start with our guests with finding out why you chose cardiothoracic surgery and specifically thoracic surgery.
So during my residency, I was not very involved in thoracic surgery at the beginning and even in vascular surgery, but I had 6 wonderful semesters where I was inside a very great team and I deeply involved myself in the field. And I feel that it seems for me evidence that I needed to do this thoracic surgery and vascular surgery. That's how it started. And I was very young. It was during my second years of resident.
Nice. So it was sort of, you fell into it and then just found your passion for it unexpectedly. Yes. Nice. And then how did you sort of get into obviously once you decided that was your specialty, how did you find yourself becoming such an expert in segmentectomy?
So in fact, I was doing at the beginning both specialties, vascular and thoracic surgery, but after 10 years of professional practice as a senior, I have been invited to join a very great team in French, led by Dominique Gossot. And he was the first French surgeons doing minimal invasive surgery. And that's how all the things start again with minimal invasive surgery, VAT surgery, rat surgery, and even endobronchial treatment right now. So it's the journey of minimal invasive surgery and lung sparing techniques.
Nice. So you've been there right at the forefront of it developing in France and taking it off, which, you know, is amazing. And what you're doing for our patients is great too. I thought we'd now move on to talk about the topic, segmentectomy. And I always like to give our listeners a bit of a background to what it is. If you're a medical student, you've never heard of what it is this will help. A segmentectomy is an anatomical resection of one or more of the bronchopulmonary segments of the lung. And it's, you have your lobectomy where we take a whole lobe away, or you have a wedge, which is non-anatomical resection. And this is something that respects the anatomical planes because each segment we take out has its own bronchus, artery and vein. Of course, we'll do lymph node dissection with it, and that is really important as well. Historically, this was developed and used mainly for those patients who couldn't, a lobectomy would remove too much lung tissue and they wouldn't cope with this. So it was to preserve the pulmonary function. But actually in recent years, we've now come to realise that it is non-inferior to a lobectomy in, the right cases and can actually offer just as good an outcome. How did we develop this technique of segmentectomy?
So as you said, it has been developed first for patients that could not tolerate a lobectomy. It was also to preserve the lung function, but sometimes because they have some comorbidities and we had the thought that a lobectomy could be very difficult for them in the postop period. And the segmentectomy was developed even by thoracotomy. It was a well-known operation and it starts to be proposed for these patients to be able to offer for this patient a surgical option because we know that the alternative option was not as good as the surgical option, meaning SBRT or other treatment. And when it starts, it was few teams very involved in, as you said, anatomical dissection, because the segmentectomy, the main definition is to control each elements of the segments, the bronchus, the artery, and the vein. And it's how it starts. And during that time, we had a lot of studies coming and trying to put evidence that in fact segmentectomy could be offered even for patients that could tolerate a lobectomy, and that could also be a valid option as an oncological operation for these patients too, in some specific indication. And I think we will go through that during this talk.
Yeah, great. So yeah, as you said, there are specific indications that you need to do. It's not, not everybody is suitable for a segmentectomy. And I think that's the really key thing I think trainees need to take away is this isn't for everyone, and it isn't an easy operation. Just because you're taking something smaller doesn't mean that it's easier. Actually, it's probably more technically difficult because you've got to work in a very 3D structure and respect those anatomical planes. And you've got to pick your patients right. The main indication would be for a sort of stage 1A non-small cell lung cancer, peripheral, less than 2 centimetres. It's got to be greater than 50% ground glass appearance or a long doubling time on surveillance, because the way the technique happens is it needs to be peripheral. If it's central, it can be more challenging. The other indications would be patients who have got limited pulmonary reserve or previous lung surgery, emphysema, where you need to spare the parenchyma. And also the other thing to think about is things like metastatic deposits. It can be useful for that, for colorectal cancer with metastatic lung disease, and other benign diseases. Actually, it's becoming more apparent for that. What is the most important features that, influence your decision when to perform a segmentectomy over, say, a lobectomy or a wedge?
So as you said, we are based on the CT scan. We try to avoid some solid nodule and some pleural involvement because we know that is not a good indication for these patients. For metastatic disease, it's a very great operation because it's an anatomical dissection and you can treat some deep metastasis by sparing some lung function for the patients. And for non-small cell lung cancer, as you said, the key features on the CT scan is to be able to be sure that the lesion is peripheral, that is not solid cancer with a double time too big. So it's not a good indication for segmentectomy. And also work on some 3D reconstruction that could help you to define where is the lesion, what is the anatomy of the lesion, and also to assess the margins. Because if you want to do a segmentectomy, you need to be oncological for a non-small cell lung cancer. So it's very important to have a very good definition of your planification operation.
Yeah, I think that's important for trainees to remember is there's no point doing this if you don't get the margins, because you're not going to help the patient. You're better off doing a lobectomy so that you definitely have your margins than leaving your patient with cancer, because otherwise you've done them a disservice.
Yeah, and we also focus on lymph node because if there is any suspicious lymph node, and that we are very strict selection for the patients, and the patients needs to be endero, and we also assess also the endero status during the operation.
Without going into too much detail, just so our listeners understand, why is it not good in small cell lung cancers or solid lesions and lesions with a fast doubling time?
So I think at that time we said it's not good, perhaps because this solid lesion is more aggressive than the one that is mixed or pure GGOs. There is few studies coming saying that perhaps for some pure solid lesion, it could be also a valid option depending on the histology. For example, micropapillary non-small cell lung cancer is a very aggressive behavior, and probably the segmentectomy is not a good option. But for some, as in others, pathological features, it could be proposed. But what we know is the two big trials that has been published 2 years ago. And in these trials, the patient selections were patients with more than 50% of mixed part of the lesion, meaning that there were some solid patient lesions, but mostly patients were with a mixed GGOs. And so we know that if we want to correlate with these two trials, there was positive trials saying that segmentectomy could be an option. For the real world, data, we need also to be as same as the trial. And we are still waiting for some Japanese trial where they assess these specific questions. Can we do that for segmentectomy for pure solid lesions and even between 2 and 3 centimeters? And we will have the answer in the years coming. So things are evolving. And at that time, we say it's for 2 centimeters tumors, part solid tumors.
So actually, it's not that it isn't good, it's that we don't know yet. And actually, our understanding may change in the future. You know, as you're talking about, there's 2 key trials, the JCOG and the CalGB trial, and they're only published, a couple of years ago. So we are really, it's a new technique, and therefore the future trials may actually say that we can use this a lot more. And thinking about these trials, for trainees to understand, what are the key take-home messages from these 2 trials?
So the first key messages was segmentectomy do as well as the lobectomy. Even on the Japanese trial, the segmentectomy was doing better than the lobectomy for the patients selected, meaning peripheral lung non-small cell lung cancer, stage 1, with the CTR ratio superior to 0.5 on the Japanese trial. The difference between the 2 trials was the American one, the CILBG. It was allowed inside the subgroup of subglobal resection to also include some wedge resection. And even there was more wedge resection than segmentectomy inside this trial. So they are quite different in the conclusion, because the Japanese one is segmentectomy is an option, and they are not speaking about wedge resection. Meanwhile, on the other hand, on the American one, it was wedge resection, and segmentectomy could do as well as a lobectomy. But we need to also to say that it was very highly selected patients. On the Japanese trial, there was assessment during the operation based on the margins, based on the lymph node assessment. And also on the CILBG, the randomization just come after the N0 status confirmed per-operatively. So it means that if we want to take these results, we need to do the same very precise evaluation of our patients to be sure that we will offer the same results. And there was some other key points, like in the Japanese trial and also on the American one, there was a higher local recurrence after the segmentectomy operation, but it does not correlate to less survival at 5 years. It means that even if there was a higher local recurrence rate, the survival was quite similar. It means that we could offer a new treatment for these patients and have no higher mortality for these patients. And that was a very, very important point also. And what is also interesting is that we know that we are getting older and older, and that even a patient that has a first non-small cell lung cancer, he could, in the years after, have a second one. And when you have a second cancer, not small cell lung cancer, it is very important also to try to treat that with a curative intent. And what we have seen in these 2 trials is that on the Japanese one is very important to underline that the patient on the segmentectomy group has a better option, surgical one, for the non-small cell lung cancer when it came at second time than on the other group. When you have first a lobectomy, usually you have an alternative treatment when you, at the end, have a second non-small cell lung cancer. So this preservation of the lung function could offer a new curative option for the non-small cell lung cancer when it comes again, and that's very important.
Yeah, it's really interesting. I think these papers are really good for people beginning to read papers and understand and put it into practice, because, a few bits of really key points is that what they do in trials isn't always feasible in real life. And therefore, if your outcomes differ, yes, it's understandable because you're not doing it as precisely as the trials, because actually that isn't applicable. And should trials, begins to get you thinking, should trials be more focusing on real life situations?
That's why my key message will be based on these two trials. It's very difficult to say that the wedge resection, for example, is an oncological operation if you're not doing like on the CILBG. It means frozen section on multiple lymph nodes to be sure that the patient is N0 status. And if you don't have the access to the pathologist or access to the frozen section, you need to be very more traditional and still offer an oncological operation that has been validated. And perhaps the segmentectomy is the best option. So that's why we are involved on that, and we need to learn how to do the segmentectomy.
Yeah, because, I know that in the UK, the ability to do the frozen section is, it's not as, available for doing it for all the lymph nodes.
And that's real world, and we need to work with the real world. And for all surgeons, we need to offer the best option for the patient based also on how it works, how the hospital have any, teams collaborations, and that's very important.
Yeah. And the other thing is taking that fact that, yes, there may be higher reoccurrence, but that doesn't correlate with worse outcome. And that's important because actually outcomes should be, life expectancy should be one of our main focus, and quality of life, not just reoccurrence rates.
Yeah, for sure. And that was perhaps one of the frustrating results coming from the Japanese one, because we were expecting a better lung preservation function evaluation after the segmentectomy. And we've seen that after 2 years, in fact, lobectomy and segmentectomy group has quite similar lung evaluation. So there was some answer to that. Perhaps it was not the good parameters. The FEV1 is not the good one to assess the lung function, and perhaps to be based on the quality of life of the patient could be the best option, because the patients wants also to have a better quality of life. And that we know that segmentectomy give a better quality of life than lobectomy.
Exactly. Great. Thank you for taking us through those in a really nice way. So if you think back to the procedure itself, we're going to have to be doing some preoperative planning. So we do things like thin slice CT with 3D reconstruction. And that's so that you can understand that specific patient's anatomy, because there's always going to be variations. And as we mentioned before, you've got to get your head around the anatomy of the patient you're operating on before you even start the operation. You need to identify the tumour location, which segment, which subsegment, what your margins are, as we've talked about. You need to plan those margins, so you can do that using the 3D images, so you know where you're roughly aiming. And you can sort of simulate it to help it calculate the margins, so that you know you are going to have a good enough margin. We need to evaluate a patient's lung function, and we need to think about staging those lymph nodes. What would you say is the main, the most important aspect of preoperative planning?
So I think for juniors, the 3D planning is a fantastic tool to learn how to perform a segmentectomy. So as you just said, each patient is unique. Each patient has his own anatomical features and distributions. So we need to be for each patient very targeted. So without a 3D reconstruction before the operation, you can't assess the anatomical variation coming from the artery, the veins, or even the bronchus. So that's very important, just not to have bad discovering during the operation, and to be safely involved during the operation for the tasks you have to do. And also it's very helpful to know which segmentectomy you need to do. Sometimes based on the tumor locations, you perhaps know that you have to do, for example, a S1 segmentectomy. But when you try to assess the anatomy, vascular or venous drainage, for example, you see that it would be impossible to do that segmentectomy, and that it's very important to know that before, so you can come to your patient and say, based on your venous drainage, I need to perform a S1 plus S2, for example, because it's a common drainage. Or based on your planifications, it cannot be just one segment because the margins are not enough, and I need to take out also a subsegment or even two segments at the same time. And sometimes I went to see my patient and I said, you know what? Based on your 3D reconstruction, I'm obliged to do a lobectomy. So we would have to discuss, can I do that? Or do we have to think about an alternative treatment? Because perhaps you can't tolerate a lobectomy. So it's very important to do the 3D segment planification before the segmentectomy, because otherwise you will sometimes not choose the best option for your patient.
Great. So this planning means that there should be no surprises in surgery. You should know what you're doing when you're going in with the best, not have to change plan.
And usually we use the 3D reconstruction for the junior also formation. It means that we ask the junior to work on the 3D reconstruction and to say at the multidisciplinary board that we have for all surgical patients operated on the week after, to say what is the plan, what segments he will do, and how it starts by each vessel, because for each segmentectomy, there is different way to approach that segmentectomy. And it's a very, very useful tool to help the juniors to perform a segmentectomy and to learn how to perform the segmentectomy.
Yeah, amazing tool. So if we think about those segments and the sort of surgical anatomy, we have our two lungs. Our lungs are split into lobes, and each lobe is split into bronchopulmonary segments. And each of these segments is drained by an artery, drained by a vein and supplied by an artery, and has a bronchus. So I'm not going to go into too much detail because this is something that's probably more visual than audio. But just remember that in our right lung, we have an upper lobe, and that has an S1, which is apical, an S2, which is posterior, and an S3, which is anterior. The middle lobe of the right lung is then S4 is lateral, S5 is medial. The lower lobe, S6, is superior, S7 and to 10 are basal. For the left lung, the upper lobe, S1 and 2 are apico-posterior, and S3 is anterior, and S4-5 are the lingular segments. And for the lower lobe, you've got S6 is superior, and S7 to 10 are basal. I think the thing to understand is, although we talk about, S6, which is, the commonest, the easiest segmentectomy people say, being in the lower lobe, it is quite superior. We have to remember these lungs are 3D and it's not just separated into clear margins. So it really, images do help with this, but if you can keep repeating them to try and help. There's definitely variation, and so 3D planning is vital. What techniques would you say to trainees to get their heads around learning these segments?
So I think based on the 3D reconstruction, it's very helpful to learn which segment is, and to better understand the 3D forms of the lungs. And we have a specific approach for segmentectomy that we usually also use for lobectomy. The fissure-based approach is based on a very powerful dissection of the vessels. It means that we need to identify each vessel before any dissection or section. For example, we usually use the 3D reconstruction during the operation. So sometimes we have the dissection, everything is exposed, and we come again to the 3D reconstruction just to assess and to correlate and have confirmation of each vessel before stapling or before a clip or any section of the vessels.
Great. I just thought I'd touch on the approaches that we can do. And it can be done open, it can be done VATS, but I think this is where RATS really comes into its element with segmentectomy. It's almost like it was made for it. It gives you, the ability, the flexibility. Commonly, less and less people are using, with the RATS or the VATS, a utility port and just using the instruments from the robot or the VATS when they're doing it. As a trainee, getting your head around robotic is going to be key, because this technique is going to become more, segmentectomy is going to become more proliferant. RATS is going to become much more apparent there. Why does RATS work with segmentectomy so well?
So I think RATS is give you an easier way to perform the segmentectomy, because you have to do a deeply dissection, and the easiness of the flex and of the robotic instrument give you this opportunity to do this dissection. The RADS approach allow you to have, the delineation of the intersegmental plane. Otherwise, during the VAD surgery, you need to add also that, for example, ICG injection. So there is some tools inside the robotic platform that helps you to perform the segmental resection.
Great. So let's get into sort of a bit more of a step-by-step about how to perform it. We'll keep it quite basic for our trainees, and we'll talk about an S6 segmentectomy because that is commonly seen as the easiest to perform. But of course, there's variations, so it's not always easy. You think about your positioning, and you're going to want your patient in a lateral decubitus. For your ventilation, you're going to want a double lumen or a bronchial blocker, so you can have single lung ventilation whilst you're performing this. And I think that's actually a good point, is that all our reconstruction and images are based on an inflated lung, but we have to remember we'll be operating on a deflated lung. Robotic tends to have 3 to 4 ports and arms. VAT's usually 3. How would you say to trainees to remember when setting up for these procedures?
So I have a setup for the VATs and also setup for the RADs. So coming from the VATs setup, the surgeon is on the back on the right side. So we are talking about a right segmentectomy. And the port for the camera is always on the mid-axillary lane at the 6th intercostal space. And the surgeon has 2 5mm pores. Sometimes I put my left hand on 3mm pores, but between 3 and 5mm pores coming from the posterior, so by the back of the patient. And there is one access instrument, or it's a 2 centimeters port for every staplers, and it's also the port where the helping surgeon is also using to have a grasper, to expose the lung, and so on. On the RADs, it's quite similar, but it depends also if you are using the robotic staplers or if you are using a manual staplers during a robotic procedure. So if you are using a manual staplers during a robotic procedure, the setup is the same at the VATs. But if you are using the robotic staplers, usually my anterior ports are lower to better help the robotic staplers to come inside the cavity because it needs more space to deploy.
Great. So it's similar, but you just think about where your ports
where you put your ports depending on what you will be used as instrument and mainly as staplers if you use staplers.
Yeah. And so then once we've got set up, we've got our ports in place, our next step is our vascular dissection to identify our structures. So you want to identify the pulmonary artery branch 2S6, which will be inside the fissure. You want to identify the bronchus, and then you want to identify the segmental vein at the hilum level. And this, obviously, you'll use your knowledge from your reconstruction about what you expect to find and how you expect to find them. But obviously it can be quite, when you're first doing it, difficult to identify these structures. So how can trainees, what tips can we give trainees to identify these, and where can they encounter difficulties and identify the wrong structures?
So for the first part, we identified the artery. It means that you need to have a dissection inside the fissure. So one of the difficulty when the fissure is fused. So there is some tips and tricks for the trainee to learn. For example, it's what we call the tunnel techniques. It means how to open a fissure very easily to be able to assess all vessels inside the fissure. After that, with the correlation with the 3D planning, you can identify each A6 if there's more than one for the segments, and to safely do the staplers, or even sometimes when the artery is not very big, I'm doing by clip, and I use the thermofusion, so energy device to separate the artery. Coming to the vein, usually I'm doing the vein at the second steps. So I usually like to do the vein by the hilum. So it means that I'm doing the pulmonary ligaments. And after that, I'm doing the dissection of the whole inferior pulmonary vein. And I try to assess the apical part of the vein, based also on the 3D reconstruction, because sometimes when you work on the anatomy, you see that there is some common drainage between V6 and V10. So we need to be very aware to be sure that the apical part of the vein is only for V6. And I'm doing the vein at the hilum level. And by that, you have access to the bronchus behind. You can do the dissection of the bronchus. And usually I come back on the fissure and I'm doing the anterior part of the bronchus. And it's an easiest way to control the bronchus because you have also the view on the artery. And you'll be sure that when you go around the bronchus, there's no injury of the artery just behind. So usually I'm doing the bronchus, going back to the fissure, and with the vein that has been yet separated, so I have no risk at the vein level when I go around the bronchus. And the next step that is very important for the juniors is that when you go around any structure, you need to see the structure, you need to take out all lymph nodes. So it is the dissection of each vessels and bronchus. So the lymph node assessment is for the oncological purpose, but also to ease the dissection and the control of each element.
Mm. So do you remove your lymph nodes before?
Yeah.
So in that
I'm removing the lymph node at the beginning, and I'm giving the station 11 and 10 to the pathologist to be sure that it's an N0 patients. If not, there was a discussion about switching for lobectomy if the patient was oriented to that oncological operation. Sometimes there is some patients where we said, even if it's an N1 patient, we still pursue on a segmentectomy, but it's a multidisciplinary tumor board decision before the operation. So you are not, in trouble during the operation. And when the lymph nodes are out, it's a very easiest way to control each element.
Yeah, I think that's a really important part to talk on about this, the station 11 and converting from a segmentectomy to a lobectomy. And I presume in saying those ones that you would stay at a segmentectomy that had been discussed at the MDT before would be those with poor lung function. And it may be that they wouldn't tolerate the lobectomy.
That's it. Some would not tolerate lobectomy. Even some patients who can offer an oncological operation, surgically speaking, but who can't tolerate a chemotherapy. So even if there's our N1 patient, for example, old patients, more than 80 years or 75 years, sometimes we said, even if there's an N1 patients, we will not do a chemotherapy. So sometimes for these patients, we still do the segmentectomy without, taking care of the N0 or N1 status. But otherwise, for the others, we think that it's still really important to assess the N0 status. And I'm quite sure that if we do this talk again in 5 years, perhaps we would say it's not any necessary at that time because we have more treatments, immunotherapy or targeted therapy. And we will have some data saying that N1 segmentectomy is equivalent to N1 lobectomy. But today, we have no trials that say that is equivalent. So you need to assess that during the operation.
Yeah, great. I think it's so exciting to see where it's going to go. Just to sort of recap on those basic steps with the vascular dissection, you tend to resect the lymph nodes, one for oncological, one for visualization, identify and divide the artery using clips or a sealer or a stapler, then go for the vein, and again, clips or stapler, which will leave you with a good view of your bronchus, at which point you can divide the bronchus. So then we've obviously dissected all our vessels, supplying that one segment, taking care to think about drainage that may supply multiple segments. And then we need to think about actually marking that intersegmental plane and before we can divide our parenchyma, because at this point we've divided our vessels, we haven't actually divided the lungs, so we still can't remove our segment. So there's sort of two main techniques. One is that you could reinflate the lungs after you've divided the bronchus and check that, it's the correct segment you'll be taking out and there's no extra supply to that segment. And the other is with ICG fluorescence, where a dye is injected IV, and obviously it won't reach that part you're going to take out, so you know where you're going to take it out and you can mark it with electrocautery. When do you use each of these, and positives, negatives?
for me, the main technique is the ICG injection. But I've been using during years inflation deflation technique. So you can still use that technique, but I really think that the ICG injection is more precise. So since when we got that technique inside the OR, we totally changed, and we're not doing anymore the inflation deflation mode, just in case the ICG is not working. Mm-hmm. So inflation deflation has the advantage to be very easy, because you don't have to have the ICG colon or in the Firefly mode inside the robot. But there is the ability to have some communication coming, what we call the cone spores. It means it's peripheral communications by the segmental plane, and sometimes it's less precise than the injection technique. That's why it could give you a bad delineation of the intersegmental plane and not the right delineation of the intersegmental plane. Coming to the ICG technique, it's based on vascularization, but it's very precise. And with this technique, if you have done a 3D planning, and if you have treat and divide the right artery, you have the right definition of the border of your segment. And based on the ICG technique, we see that what we were doing with the inflation deflation, it was sometimes some straight line. With the ICG, we see that in fact the border is sometimes more curved and very more precise, and that helps us to be, with the right delineation of the segments. Because if you leave some segment that you should have removed, it could be also some condensation, some, it's not vitalized, it's like a dead segment. So it's very important to do the right delineations and to cut and divide on the right delineation of the segment.
Yeah, because with any surgery in any specialty, leaving devascularized tissue is just, is a recipe for disaster, because it will necrose, can get infected. And so actually that's a really nice point to think about, that it's not always straight lines like we, imagine in our brain. So it's really useful. And that's where the robot as well is, excellent, because it's, built into it.
Yeah. So we need to say also that sometimes ICG technique is not very as good as expected. For example, in very emphysematous patients where there is less vessels inside, sometimes the coloration, the green coloration, is quite not clear. So using at the same time the inflation deflation technique could help, for example, to assess the right delineation. So I for juniors, knowing the two techniques, it's a good point, but they need to be engaged in the ICG injection.
Yeah. So ICG is the first step, but don't forget your basic techniques.
Yes.
And so then once you know where you're going to be taking, then you need to be dividing this parenchyma using a stapler or an energy device, following those where you've marked for that intersegmental line, and placing it into an endobag. And I think the thing to remember, and it's hard to get your head around when you're first training, is it's a 3D structure like a pyramid. When you place a stapler, you're not just cutting top to bottom, you've also got to be thinking about your base. And that can take some time to get your head round.
Yeah, and we have few tips and tricks for that.
Yeah.
It means that we need to be to do what we call step by steps and very little steps. It means sometimes we want to use the biggest staplers just to save some staplers and so on, but it will not allow you to do the pyramidal shape of the lung. So sometimes just using the 45 staplers, for example, it's an easiest way to perform even on the lower lobe, the intersegmental plane. And also we have a little tips and tricks is that we use a clamp before. So it compressed the lung, and it's very helpful to ease the way for the stapler to come and to compress the lung after. So by trying to use that two little tips and tricks, it could help for the intersegmental plane division.
Yeah, definitely. There's some nice tricks there. And then obviously we're going to place it into an endobag, and we're going to check for any leaks, place our chest drain, and get out of there. If we think about the whole operation, what are some of the common pitfalls or errors that trainees need to watch out for?
So the first one, I think, is to have a bad location of the tumor. It means that you think, because you just base yourself on the CT scan, that, for example, the tumor is on a S9 segment, And in fact, you take out this S9 segment, so you do a very difficult segmentectomy, and there's no nodule inside. So the main, I think, pitfall or error is not to have a 3D reconstruction where you are sure where is the tumor and which segments, if you need to take more than one, you need to take out. The second error is to believe the CT scan and not to assess the anatomy, because it's very difficult. There is a lot of variation. We've said that. So also working without a 3D reconstruction, you can be in trouble. And sometimes you don't know that you're in trouble during the operation, but you know that you're in trouble after the operation because you have, for example, a venous ischemia because you didn't take care about the venous drainage of the segments, and it's complication for your patients. So that's a main error. And the last one, perhaps, it's the poor intersegmental plane delineations. So we just spoke about that, and you leave some dead part of the lung inside the thorax, or also when you have not done a good lymph node dissections. So the status of the patient is not very well determined after the operation. Your oncological operation is not really an oncological operation.
Yeah. And I think that is one of the worst things. If you think, I've got my margins clear and I've got everything done, and you've got all the lymph nodes.
And regarding the margins, we also ask the pathologist to assess that the margin is enough. It means that if the lesion is at 4 or 5 centimeters, we try to avoid the frozen section, because as everyone, we have also some difficulties to get the pathologist inside the OR. But when the lesion is at least at 1 centimeter from the border, from the staple line, we ask for frozen section to be sure that we are not too close to the delineation of the intersegmental plane. Otherwise, we can add 1 centimeter more, or we take 1 subsegment more during the operation to be sure that the margins will be enough for the patient.
Yeah. And I think that's a really key point, is doing what's, you need to do the utmost for your patient in that operation. And if we think about the post-operative care and complications, actually, it's the same as if you were doing most other operations in general. The complications tend to be the same, things like pneumonia, hemothorax, empyemas late and things like that. But they do tend to have reduced recovery time. That is a benefit. They tend to be up and out about quicker. But some of the some of the negatives people say is, yes, there's some higher rates of reoccurrence, but as we said, this doesn't necessarily correlate with change in survival. And sometimes we can get some inadequate lymph node sampling. Are there any other specific post-operative care parts we can offer to our patients, or complications that our residents and trainees need to be aware of?
So when I'm performing a segmentectomy, usually I'm still looking very carefully to air leakage, because the intersegmental plane is very long and all the stapler line could be at risk for air leakage. So during the operation, I can add some sutures. Sometimes I'm using sealings, but just to be sure that I'm not leaving the operative field with some air leakage that would prolong the hospitalization time of the patient. Otherwise, I need to say that I love segmentectomy, because usually the post-op recovery is very fast and with no complication.
So that we're coming to the end of that. So I think some key points to think about with this, for our residents and trainees to take away, is that, a segmentectomy is equivalent cancer control in these early stage disease, with better lung preservation, shorter hospital stays, and like you said, post-operative course is quite smooth normally. But you need to remember that it's not a shortcut, it is not a lesser surgery, and it's a precise one that is earned through good knowledge of the anatomy and preparation for the procedure. And it can be more technically complex and requires a lot of that pre-planning. And just pick your patients right, not for those central, deep and aggressive lesions. And as for trainees, how can they learn this technique? I think the takeaways that I've realized from this is using that 3D anatomy and planning is really helpful for trainees to get their head around planning the operation and going to the MDTs and discussing our plan for each procedure. Start with those simpler segments, S6, S1 and 2. Watch those videos. always simulation models can help, but they're not a replacement for the operation. Thank you so much for coming on. And before we stop, I always like to ask my guests sort of a question about if you could reflect on all of your training and you could go back to yourself right at the beginning of your residency or right at the beginning of your thoracic training, what bit of advice would you give yourself?
That's a good question. Probably I will say surgical mentorship is the best path to training. I feel that I'm the surgeon that I am right now because I've been working with so wonderful people and I learn a lot from these people. So for juniors, it's very important, to stick to one people and just learn as much as you can from these surgeons. And also, I always say to my juniors, your patients deserve an oncological operation. So it's not counting on your speed, it's counting on your precision. So I just do not want you to do a speed operation. I want to do you an oncological operation. That's the main point.
Great. That's, I think, a really nice point to end on. So thank you so much for your time. And it's been a pleasure having you on the podcast.
Yeah, thanks, Alice. It was a pleasure also to be with you.
And thank you everyone for joining in and listening to this month's episode of the Atrium. I hope you found it useful. Stay tuned for next month's episode.